Sounds good. We do have more questions. However, let's get to Sina and then we'll hop back up for these questions at the Q&A segment. So Sina, as most of us know, is the scientific director of MSite Corp. He's a resident expert in tissue engineering and regenerative medicine. And he has a very strong biomedical background, which is an excellent framework for tackling all these highly complex pathways and mechanisms involved in regenerative biologics. So he's been diligently working on addressing knowledge gaps in treatment protocols and how biologic formulations can be most appropriately paired with various conditions. So with that said, let's hear from Dr. Farzaneh and hear his insights on tonight's topic.
Thank you so much, Natalie. So, can you see my slide?
Let me
Yes.
stop sharing.
Uh, okay, good. So, hello everyone, and thank you for joining us for Regenerative Edge, MSide monthly webinar series. Thank you as well to Dr. Vatska for sharing his valuable clinical insights and treatment protocol. Over the next 15 minutes, I would like to focus on the pathology mechanism, mostly molecular mechanism behind of the different stages of the frozen shoulder and the rationale of using PRP, watt bioformulation, and the concentrated plasma protein for frozen shoulder condition. So I would like to immediately jump to the PRP. So, PRP has become one of the most promising orthobiologics tools because it is autologous, point of care, minimally manipulated, affordable, and adaptable across different tissue through bioformulation. So we easily can change the function and properties of the PRP by adjusting the leukocyte contents and adding the concentrated protein or not adding that. So beyond the platelet activated PRP release a rich secretome of the growth factors upon the activation, chemokines, cytokines, extracellular vesicles, mitochondrial signal, and metabolic mediators that can support angiogenesis, immune modulation, macrophage polarization, inflammation resolution, and tissue repair. But today we are going mostly get the benefit from the immunomodulation and anti-inflammatory properties of the PRP. So, in another side, when we have actually PPP as the side product of the PRP, which was often treated before as a waste, while is actually a valuable reservoir of the small molecules, including the proteins, secretomes, different micro RNA, mRNA, etc., etc. Although plasma is mostly water, but it has something around 7 to 8% of the proteins. We have tons of proteins in our plasma, but 23 proteins are going to be listed as the most abundant protein. And we are familiar with some of them, like alpha 2 macroglobulin. And when we concentrate the PPP to have the concentrated protein, we usually call that as A2M, but we're going to discuss about other protein today as well. So regarding to the concentrated plasma protein, which contains so many proteins, as I mentioned, I would like a more focus on these two proteins today with a strong relevance to frozen shoulder biology. A2M, alpha-2 macroglobulin, and serpin family proteins. I would say these are one of the most abundant protein both alpha-2 macroglobulin and serpin families. We have as a baseline 2.2 to 4 milligrams per ml A2M in our plasma and 1.5 to 3 milligrams per ml serpin families in total. And we can concentrate them a couple of times, at least 5 times, based on the final volume we are gonna get after using the ultra filtration. However, Mostly when we talked about these two proteins in our previous webinars, we talked about the anti-protease activity and properties of these proteins. But the things today we need to focus is something else because in the pathology of the frozen shoulder, we don't have that much MMPAs, and that's the problem. Before we mostly focused on the MMPAs, proteases in general, enzymes, and we mentioned with these proteins we can inhibit proteases, but in this case we don't have proteases. So how this protein could help us, and we're gonna discuss about them in next few slides to understand where, when, and why PRP and concentrated plasma protein may benefit frozen shoulder treatment. We should first look at the normal shoulder capsule. In a healthy shoulder, the synovium, capsule, cartilage, and joint cavity support a smooth and pain-free motion. The capsule is a collagenous but flexible membrane, mainly composed of type 1 collagen and elastic fibers with limited vessel and nerve fibers. Fibroblast maintains this balance by producing ECM proteins that provide a structure while preserving mobility. However, in the early stage of the frozen shoulder, the main pathology is hypervascular synovitis. The capsule and synovium become infiltrated with inflammatory cells, leading to cytokine secretion, pain, and early capsular irritation before dense fibrosis and contracture become dominant. However, in the late stage of the frozen shoulder, inflammation goes away to fibrosis and contracture. The articular capsule becomes thickened, fibroblasts differentiated into myofibroblasts, and excessive type of collagen type 1 accumulates. As the capsule tightening, the axillary recess volume decreases, directly limiting shoulder motion and producing the classical stiffness. As Dr. Laska mentioned, and most of the textbooks, they actually staging the frozen shoulder in 3 stage clinically, based on the pain and range of the motion. But for this framework, I would like to add an earlier pre-adhesive stage where pain begins before major stiffness develops. Stage 2 is dominant by inflammation with worsening the pain and early range of motion limitation. And the stage 3 is the adhesive or stiffening phase where pain may plateau, but actually capsular stiffness and functional loss become more prominent. And in the stage 4, which is usually we consider that at thawing stage marked by reduced pain, especially night pain, and gradually recovery of motion over months to years, as Dr. Latska mentioned. So if we consider these 4 stages from the pre-adhesive stage as the earliest stage, in a stage 1, the frozen shoulder is mainly a pain-dominant inflammatory condition. The key pathology is synovitis, driven by cytokines such as TNF alpha, interleukin 1 alpha, and interleukin 1 beta, interleukin 6, COX-1 and COX-2 activity. And at this point, there is no fixed capsular contracture yet. But macrophages, mast cells, angiogenic cells, and neurogenic inflammation begin shaping a pro-inflammatory and pro-fibrotic environment. So in the next stage, which is frozen shoulder stage as freezing stage, so it actually enters a key immune fibrotic transition. And in this stage, actually T cell activity becomes more prominent, specifically T helper 1 and cytotoxic T cells. through the interleukin 17A axis. The main player here is the interleukin 17, although we have other inflammatory cytokines like interleukin 6, interleukin 8, a little TNF alpha, and also we are going to see the NF kappa B signaling pathway, but the main player and the dominancy is around the interleukin 17A. So what can we do in the pre-adhesive and the freezing stage if we want to consider treatment at this stage? Definitely PRP, even a standalone, would help because we know PRP as one of the great anti-inflammatory biologics. And if we consider the monocyte-rich bioformulation, it would be more helpful here. Always, when I'm talking about the monocyte rich, I'm talking about the role of the monocyte. But we need to recognize that monocyte rich has also huge amount of the lymphocyte. If we make the monocyte rich PRP, the monocyte concentration is something around 90%, and the lymphocyte is around 80 to 90%. And here, to fight with the interleukin 17, we need T regulatory T cells, Treg cells. And when we have the lymphocyte with the platelet, we are going to have more Treg, and the lymphocyte is going to lymphocytes are going to follow the platelet signals as a guidance. So in this case, if we make the monocyte-rich PRP, which is the lymphocyte-rich PRP, would be more helpful to fight with the inflammatory cytokines, specifically interleukin 17. So there are a couple of the studies actually, so we could consider them as the evidence. PRP has been shown to target and downregulate key inflammatory mediators. Evidence shows reduction of the cytokines and chemokines such as TNF alpha, interleukin 1 beta, interleukin 6, interleukin 17A, and a matrix degradation enzyme like MMPase. So this support the concept that PRP is not only regenerative, but also immunomodulatory and anti-inflammatory. As I mentioned, if we make the monocyte rich, which is the lymphocyte rich in this case, it would be very, very helpful for this specific purpose. If we continue the staging, stage 3 is going to be the TGF beta dominant fibrotic phase. So here, fibroblasts shift toward the myofibroblast, collagen 1 and collagen 3 accumulate, and the capsule becomes thickened and contracted. PDGF support the fibroblast expansion, while TGF beta drives matrix deposition and capsular fibrosis. So we also see the AGE, which is the advanced glycation end products, can further stiffen the capsule through the collagen cross-linking and NF-kappa signaling pathway. So what we have in this actually stage, the dominancy is around the TGF beta signaling. So, and we're seeing that in most of the fibrotic environment, there is a kind of a conflict here because we know PRP provide TGF beta for us, platelet secretes TGF beta for us. And here, the problem is the TGF beta signaling pathway. That's why, in this case, we need to supercharge our PRP with the concentrated plasma protein, or even if we add the PPP, since it has all of the small molecules in it, so we could actually modulate the fibrotic pathway. So how? As I mentioned earlier, A2M is one of the key concentrated plasma protein that we consider as the player for fibrotic stage frozen shoulder treatment. Its classical function is protease inhibitor, and we talked about a lot. A2M uses its bait region to trap active protease and help clear them from the tissue environment, and we discussed about that. Mostly in the osteoarthritis, degenerative tendinopathy, we see that. However, A2M also has another important role. It can bind growth factors and cytokine, potentiate some of them, like IGF-1, as I remember I discussed in our previous webinar. And also, it can reduce the biologic activity of some other growth factors, like TGF-beta, like PDGF. This is highly relevant for stage 3 frozen shoulder, where TGF-beta driven myofibroblast activation and collagen deposition dominate the pathology. So here, there are a couple of the published evidence, and they show how A2M can control TGF-beta signaling pathway when we use the concentrated plasma protein. Another protein similar to A2M, which is the serpin family, serine protease inhibitors protein. Mainly, we know them as anti-protease. We have 37 different types of the serpin in our body. 20 of those serpins are anti-protease, but the 17th one could be served for different purpose and also mostly for anti-fibrotic role for different tissues. For example, serpin A1 or alpha-1 antitrypsin has been shown to attenuate fibrosis by suppressing the TGF-beta-1 induced mesenchymal transition. In this graph, you could obviously see serpin A1 clearly reduces the collagen expression and collagen deposition, suppressing its anti-fibrotic activity of actually TGF-beta-1 signaling pathway. Other member, including serpin F1, serpin A4, and A3, also show, based on the evidence, for regulating the fibroblast activation, matrix remodeling, and fibrotic progress, all of them through the controlling and regulating the TGF-beta signaling pathway. So for the stage 4, actually, which is, we call that as the healing or resolution phase, pain usually slowly decreases because inflammation becomes less active, but still we have inflammation. But stiffness can remain because the capsule still needs time to remodel. In this phase, certain macrophages help clean up inflammatory signals, while a specific fibroblast group help recognizing the extracellular matrix reorganization and reorganize the extracellular matrix. Together, these cells support gradual softening of the capsule and a slow recovery of the shoulder motion. So the takeaway for frozen shoulder, if we are going to treat that at the initial stage, PRP standalone could be helpful since we are going to target inflammatory cascade. But when we pass the freezing stage to the frozen stage, actually we have a transition from inflammatory to fibrotic. In the fibrotic stage, the main player is the TGF-beta signaling pathway and then PDGF. So in this case, platelet standalone could add a little more risks. That's why when we equip that with the concentrated protein, actually A2M, serpin proteins, and also some other proteins like ApoA1, they could take care of that, and they could regulate the excess amount of the TGF-beta, VEGF, and PDGF to avoid fibrotic cascade and stop the fibrotic cascade. Thank you for your consideration.